Hello everybody, this is Matt Atwood again. Now we're in segment number 2, which I like to call Allergy 101. Now these key concepts that we're going to be reviewing right now are going to be the basic concepts that you will be explaining to patients over time. So pay attention to these. If you have any questions on these, you want to be able to call your pharmacy to be able to get some of these specific questions answered. But if you learn and pay attention to this, and you might want to watch this video over and over again until you make sure you've got these key concepts down. But this is where the education begins for the patient. So the more you know this information I'm about to go over with you, the better off you're going to be able to provide value and better care for your patients that are suffering from allergies. So first, let's go over the key questions. Number one is, how often do you see these types of patients in your practice every day? So a lot of times you're going to get the sniffly is going to be, the running nose, the rhinitis, the postnasal drip, all of that from the sinuses is going to show up first. Then you're going to have potential skin issues like eczema, itching, reddening skin, hives. You might get some nausea, conjunctivitis and watering eyes. That's pretty common for allergy. Sneezing, obviously you're going to be getting that runny nose. It's going to be tickling your nose and you're going to want to sneeze a lot. Swelling of the face, of the sinus pressure area, which can cause headache, cough, stomachache, diarrhea. That's going to be more of a food allergy issue. And then you've got just basic, fatigue and ailment. You just don't feel good. I mean, when you know that you've got allergies bad and your head feels like a 10-pound bowling ball, you don't feel good and you know it. And so when you see these types of patients, these are all typical allergy symptoms. And so you want to be able to identify it and say, okay, I think we have a program to help you. Second thing is, what are you doing about it? When you see these types of patients, do you just say, here's something over the counter, good luck, and just kick them out the door? Or do you actually want to treat them and help them and identify what's causing these issues and be able to provide a service that will be able to desensitize them safely without any risk of anaphylaxis, like it would with an allergy shot? So take the old way of doing allergy with the individual needle scratching. Don't do that anymore. We've got plastic applicators. Or with allergy shots, weekly visits. Nope. Don't want to do that either. We can do that in or out of practice. We can just sit there and do a prescription, send it directly to the patient's home, or send it directly to your office where they can pick it up. And that's what we're going through real quick. Okay, on the pediatric allergy march, pediatricians, please pay attention to this because you're going to need to know this inside and out. And you can even Google it too. There's a ton of clinical research on pediatric allergy march. And what it is a cascade of going from low allergy, early allergy identification, all the way up to asthma. And it's a progression. And if you can identify and catch this early, that's the key. So the first thing you're going to see is going to be dermatitis. And that typically happens from atopic dermatitis, typically happens from either like an eczema or a diaper rash, or even gastroenteritis. You'll see that peak up between a 0 to 12 months figure. But that typically starts with an egg, cow milk, gluten, or soy allergy. It's always going to end up being a food allergy. Now, why is it between 0 to 12 months or 3 to 12 months, and then all of a sudden after 12 months it seems to go down? Well, the reason for that is, think of the anatomy. An infant's stomach and gut is leaky. It's not fully formed yet. And what is it supposed to be, based on millions of years of human evolution? It's supposed to be eating breast milk, right? So during the breast milk side of this, it usually comes in with all the proteins and fats and carbohydrates that a baby needs to be able to mature naturally. But what have we done? We have, the mother has to go back to work earlier. So you start supplementing. When you start supplementing, you supplement with formula. Guess what's in the formula? Egg protein, milk protein with either whey or casein, or gluten is also added to it, along with high fructose corn syrup, along with soy. So you've got a bunch of potential highly allergic issues that are now going to be absorbed in an infant's body when the gut is leaky, and those proteins are basically foreign to the body. So as those proteins go through the gut walls and they are identified by the immune system as a foreign protein, what is it going to do? It's going to attack it. And when it attacks it, it causes inflammation. When it causes inflammation, now you've got an infant with allergies. So that's why it typically takes anywhere between up to 12 months for the gut to start to seal. So that's why after that 12 month, the symptoms drop. But before the 12 months, you've got issues. If you're dealing with a patient or a colicky baby, do not give them any vaccines. If you have any kind of immune response or inflammatory response triggered by allergies, because that's specifically limited by pediatricians. You're supposed to be inspecting to make sure that there are no autoimmune disorders before you're giving a vaccine. Now, in the previous thing on the statistics on the previous segment, on segment 1, we talked about dermatitis, gastroenteritis, rhinitis, otitis media, conjunctivitis. Those are all early signs of allergy up to a 3-year mark. And then once you see that, now you've got like an 80% chance of anybody that has a rhinitis or an infection like a sinusitis now gets up to a high risk of asthma. So that's why in the previous statistics, when we talked about the pediatric allergy march, we were talking about early signs of dermatitis or gastroenteritis or ears, eye, nose, throat issues are now going to be linked to any patient after 5 years old that has asthma. Okay, so that's why you want to identify it early. You want to take care of it early, and if you can create a sublingual immunotherapy that's going to be a low dose for pediatrics like we have, this is a very low dose therapy process that is done on a daily basis, and it can be used on children as early as 1.5 years. Oral allergy syndrome. Okay, now when this comes into play, when you have patients that say, I've got food allergies, what you want to do first is you want to be able to test their inhalant allergies first, and here's the reason why. There's what we call a cross-reactive protein between what you're inhaling and what the body sees as similar to, let's say, for example, an alder protein or an alder pollen. When it's brought into or introduced into your immune system, that protein has been triggered now to be able to see that alder protein and trigger a histamine response to it. Now, the problem with that is that a lot of proteins that you eat are very similar in the structure of the protein that is the alder pollen. So what happens is sometimes on something like an alder pollen, you'll look at apples, almonds, celery, cherries, hazelnuts, peaches, pears, and parsley. If you eat those, the body confuses the proteins from those fruits and vegetables and nuts as if it's an alder protein. So then it reacts like a food allergy, even though it's not really the food that it's allergic to, it's the alder pollen. So when you take a look at something like birch, or something worse like grass, which has an allergenicity score of 5 or higher, or of 5, which is very high. So you take a look at all these things that if you have some sensitivities to almonds or apples, it could be an alder, it could be a birch, or if you're looking at grass or mugwort or even ragweed. If you take a look at what you have right there on grass and ragweed, melons. Notorious almost every single time when I see somebody that has super high allergy to grass and super high allergy to ragweed, I can sit there and ask them, you wouldn't by any chance be allergic to watermelon, would you? Or cantaloupe or honeydew melon? And they look at me shocked going, yeah, how did you know? Well, it's not the protein in the food that you're eating is the problem. It's the protein in the inhalants, because your body thinks that those things that you're eating are the same protein that it has developed a sensitivity to on what you breathe in. So when you look at grass or ragweed or mugwort, those are direct cross-reactivity from an inhalant allergy to something that you would eat, and the body just gets confused. It reacts either way, but it thinks it's reacting to the inhalant protein. So this is where you can really help patients. This is another reason why we do the testing, is because if we can identify what is causing the problem on what they breathe in and what the triggers are, then we can identify what potential crossover or cross-reactivity to the foods that they're eating. If we can desensitize them or make them immune to the protein they're breathing in, guess what happens to the food they can eat? They no longer react to the food. So that's a huge deal for a lot of patients that are still trying to figure out on a food sensitivity diet or go through a food sensitivity test and find out they're really not allergic to too much as far as food, but they have a high allergy to something that they're breathing in. So that's why primary care is set perfect to do the first round of general screening of being able to identify a symptom, say, I think you might have allergies, let's do a test. When you do the test, yep, it looks like you've got allergies, you're allergic to grass and ragweed. Guess what? You might not be allergic to blueberries, strawberries, or watermelon. So that's good news. Let's treat your allergy to the stuff that you're breathing in, and then the rest of that stuff that your body's getting confused about will stop reacting to that as well. Now here is another key concept for the multi-regional comprehensive serum. Now what I did is way back when in 2000, what was that? God, that was a long time ago already, 2009, 2010. When I first started looking into this process, I looked at all 9 regions across the United States. So you've got the Northeast up there, have a different set of plants than the Southeast. The Southeast has a different set of plants than the very tip of Florida down there by Miami and the Keys and the Caribbean. So that's a different fauna of different plants with different pollen. And then look at something like Texas. You've got 3 different regions that hit Texas, but you've got 4 different regions that hit California. Now, keep in mind that even though these states are separated by their state lines, it doesn't mean that Arkansas and Tennessee or Arkansas and Oklahoma are only in those regions. You're going to have wind that's going to cross over those regions all the time. So it's really silly to kind of block out just regions in those specific areas, because that's called specific testing and specific immunotherapy. And when you're doing stuff like that, you don't necessarily have to do specific area in that region, because let's say, for example, in Texas, where I'm in San Antonio. Well, San Antonio is covered with cedar, and cedar is the only winter blooming plant in the northern hemisphere. So therefore, when we get our first cold snap in December, January, February, you're going to get a high cedar count. And that cedar, if it's a really high-end cold front coming in, it's going to get really windy, and it's going to blow cedar across 8 different states around Texas. So it's not just Texas. However, a lot of people that come in from California or Florida or New York or Washington that come into Texas and have never been exposed to mountain cedar, they get what we call cedar fever in the winter. It only takes them one season, then they get sensitized, and the next season they're sick, and they do not feel good at all. So what I did is I took all 9 regions, made a spreadsheet of all the different plants in those regions, and then we eliminated all the duplicates and created one general test panel for North America. And we also took that 70 tests that we created for the test panel, and we added the other 20 allergens to make it a comprehensive, multi-regional, sublingual immunotherapy vaccine. It's not just Texas. It's not just California. It's not just Florida. It is all of the North American continent, including Canada and Mexico. So just keep that in mind, that this is the most comprehensive formula across the United States. And the main reason why we do that, number one, let's say, for example, you live in California, you've lived in California half your life, and all of a sudden you get a job and you move to Texas. Well, that little pinkish area along the coast in California, let's say, for example, you've got you had an allergy when you were a kid to olive pollen. Well, olive trees are all over that area, and you've been treated for olive, but then you move to Texas, and now you're not treated because there's no olive in Texas, but there's a ton of cedar. So now you've got exposure to a brand new protein or a pollen that your body's not used to, and it triggers a sensitivity to that particular pollen. So when you're doing that, what you need to worry about is the sensitivity of being able to have to start over again. The other side of this is people like me. I travel all over the country to do allergy training and installations. So if I live in Texas and I have to go to Alaska, or I've got to go to New York, or I've got to go to the Florida Keys to do an install, and I get out there and I have sensitivity to a particular plant in that area, and I'm not being treated for everything across the North American continent, then I could typically have an allergic reaction while I'm out there in Florida on business or a vacation. So we have these things called planes that take you pretty much everywhere. So that's the reason why we build a multi-regional comprehensive serum to where one nation, one test, one therapy, we got you covered. So we do 70 of the tests, 70 allergens in the test that are all across the country, and we do 90 allergens in the sublingual immunotherapy panel. Now, the allergic threshold. This is going to be a key concept for this slide and for the next slide. Now, here's how this works. Remember that 56% of the United States is allergic to more than one allergen. They just might not know it yet. Now, what does that mean? That means that, let's say, for example, your immune threshold is the strength of your immune system, okay? If you have, and allergies are what we call cumulative. So if we know that you are allergic to mold and dust mite, and those both occupy the same space inside a house, right? But you're not symptomatic. Your body is suppressing that enough to where you don't have an allergic reaction, even though your body is sensitive to that. It's just not enough to really trigger a response that you're going to recognize as allergy. However, let's say, for example, your daughter says, "Daddy, I want a cat." And all of a sudden you bring home a cat. Now you've got symptoms, because now you're past the threshold, and you can be a little allergic to a lot of stuff and have one big symptom, or you can be allergic to one thing really bad and have one big symptom. The bottom line is you don't know until you've done the test. So that's the purpose for doing the testing in the office. So now that you can identify these things and you go, okay, I'm allergic to mold, dust mite, and cat. Well, little Sally's not going to let me get rid of that damn cat, so I might as well go ahead and decrease my exposure to dust mite and mold and start cleaning the house a little bit better, and then that'll bring me back down below my threshold, and now I feel fine. So you see how that threshold concept works? If I can do the testing and identify what's causing my trigger and then go back in and then reduce the amount of exposure to the trigger, I might be able to get back underneath that threshold to where I don't have any symptoms. I keep the cat, little Sally's happy, I'm not miserable anymore. However, if I can't get rid of that damn cat and that is driving me crazy and I am miserable to where I've got to go get my Zyrtec and I'm on it all the time, the only other way to fix that is to do immunotherapy. Now, there's only two options for immunotherapy. There's only shots and there's only drops. So this is where it gets into the allergy sublingual immunotherapy, because it doesn't matter to us what you are allergic to, because we're putting the top 90 allergens in a sublingual immunotherapy in a low dose. And imagine that like weightlifting for your immune system. The more weight that you put in there, the more tolerance you build towards all the proteins that are in there. Therefore, you are completely immune to allergies across the country. That's the concept. So as you start taking the drops, you start building that threshold higher to where your tolerance level is higher, because you're adding antigens and an increase of antigens each week over a 5-month period. So as you're adding a little more weight, just like you would be if you were, you couldn't do a pull-up the first time you go back into the gym, but all of a sudden you start doing 1 pull-up, and you do 1 pull-up a day for a week, and then you do 2 pull-ups the next day for a week, and then 3 the next day, for a week. So that's when you can start building a stronger immune system, but at the same time, you will reduce the amount of inflammatory response because you're eliminating the IgE reaction from the dust mite, mold, and cat. So those are actually going to shrink over time while your threshold increases over time, which gives you more space between your threshold and your actual allergy triggers, which now makes you more immune, because next time you breathe in those things that your body thinks is dangerous, it's not really dangerous. It's just your body is overreacting to the proteins, and we're training the body how to recognize the proteins and not respond. That's how immunotherapy works. So now let's go over more details on that cumulative effect. Like I said earlier, if you are allergic, a little bit allergic to a lot of things, it can add up to one big, massive symptom. So here's an example of anybody that was tested and where they say between a 0 to a 6 millimeter response, anything that's above the median, which is a 3. So let's say, for example, you are in an allergy clinic, and you go in and you do the exact same allergy test that you do with us in a primary care setting. Here's how an allergist is going to treat this information. It's going to say, okay, anything above the 3 millimeter is going to be, we consider, clinically significant allergy. And we're going to put that in an allergy shot. Now, because an allergy shot is so concentrated compared to our sublingual dose, which is a low dose on a daily basis, there's a big difference. And let me explain this for a little bit. Imagine doing a workout every day for an hour. So if you start on a Sunday and you come back and you've worked out all the way through Saturday, and you've worked out for 1 hour every day for 7 days. How many hours have you worked out? 7 hours total, right? But you spaced it out on a daily basis. So you were able to work out on chest on one day, legs on another day, arms on another day, back on another day, cardio on another day, abs and legs on another day. So that's how you would get the best effectiveness over a period of time, because you're consistently committing exercise and you're building muscle at the same time. Now, imagine an allergy shot. That's like what a sublingual immunotherapy is. It's a daily dose every day, and it builds your immune system stronger. Now, for example, if you were to look at an allergy shot in the same kind of equivalency is like picking 1 day out of the week and working out 7 hours. Your workout time is still 7 hours a week, but how do you recover from a 7-hour workout? You are exhausted, you are sore, and your body doesn't function very well when it's overloaded. That's what an allergy shot is. So because you have a limited amount of allergens you can put into an allergy shot, like 12, if you're allergic to more than 12, now you've got to do it in phases, and you've got to be able to identify what's clinically significant and put those in the first round of shots. And then those things that are clinically insignificant, you would not put in a shot therapy. Now, here's the trick. Here's the reason why patients that go on allergy shots say allergy shots do not work. Pay attention to this. The cumulative effect says that if you were being treated for cedar, cottonwood, mold, and dust mite. Cedar and cottonwood are trees. So in the spring, when you are dealing with cottonwood and cedar, you have massive allergy reaction and also mold and dust mite, which is indoors. You might have that during Christmas time as well, while you're indoors, like Thanksgiving all the way to January, February, depending on where you live. But these are seasonal issues, but bluegrass and Bermuda grass are blooming at the same time. So that combined effect crosses the patient's allergic threshold, causing allergy symptoms in the summer when grass is blooming. So now you are in the summer, you're getting allergy shots for cedar, cottonwood, mold, and dust mite for the year. Are you getting allergy shots for bluegrass or bluegrass or Bermuda? No, you're not, because it's clinically insignificant. They didn't add it to your shot profile. But in the summer, all of a sudden you have symptoms because you've got cumulative effect, and you're taking shots, but you're still blowing your nose off. Then in the fall, you have the same issue with ragweed and pigweed. So all through the summer, you're still blowing your nose. All through the fall, you're still blowing your nose. Why? Because they're not in the allergy shot. That's the reason why we put everything in our drops. So when we can sit there and give the top 90 allergens in the country to patients and help them build a huge, strong, consistent, compliant immune system to these particular proteins, they learn how to identify the proteins and ignore them because they realize it's not dangerous. They've seen it before. It's not a big deal. So now let's look at a side-by-side comparison between a patient that we tested back in 2008 and the same patient that we tested in 2009. Now, the patient that we tested in 2008 was allergic to over 60 items. His age was 51 years old. He had atopic dermatitis for the majority of his life. His skin was bright red and sensitive to the touch. He was asthmatic and using 3 different medications and inhalers. He had chronic sinusitis, constant sinus infections all the time, and migraine headaches. This patient was so allergic that he went to an allergist, and the allergist said it would take us 10 to 15 years of allergy shots to try and desensitize this, but you're so sensitive to so many things, you would be a high-risk patient for allergy shots. So he never ended up going into allergy shots. Because that was the only option available at the time. So the result of the allergy drops, he was allergic to 60 allergens, and then in 12 months came back and did another allergy test and was only allergic to 6. We knocked off 53 IgE responses in 12 months. It normally takes 5 to 6 years to see that kind of reaction from allergy shots. So we now have clinical data showing that this patient changed his life. This particular patient actually called the doctor. And the reason why I know this is the doctor called me to tell me, you're not going to believe what this patient just said. Remember the guy that was miserable? And I go, yeah. He goes, guess what? He just called me while he's in the grocery store and said, I can smell strawberries. I have not smelled a strawberry, a watermelon, anything for decades. I have not been able to smell anything because my allergies have been so bad. So that's when you know that you are on the right path, you are doing the right things, you are taking care of your patients, you are offering them a safe, affordable, comprehensive program that works. So now let's go over the sublingual immunotherapy. This is a universal, the top 90 allergen inhalant allergens. So universal, comprehensive, whatever you want to call it, it's the same thing. So comprehensive sublingual immunotherapy. Painless, needle-free testing, and it's affordable. So this sublingual immunotherapy, it's a needle-free testing, and it's needle-free because you're not doing the shots. You're just doing drops under the tongue, which is an amazing life changer for this. Because if you're going to get shots all the time, every week, for 5 years. That's why you only have a 20 to 25% compliance on shots. You don't get good compliance on that because, number one, you got to go into the office, you got to wait for your shot. Then when you get your shot, you got to wait in the lobby for an hour, 45 minutes to an hour, to make sure that you don't go into anaphylaxis in the lobby and die. Sound good to you? Not to me. So you can be charged up to $200 per patient for this. It desensitizes the immune system to the protein triggers that typically cause allergy, to all 90 or the 70 that we test. We actually give you a therapy for 90. And I'll show you what the therapy is on the sublingual immunotherapy section. You'll see everything that's included in there. It eliminates medication dependence. When somebody is on their asthma inhaler all the time, or on their Zyrtec all the time, or on their nose spray all the time, or they have to have they have a Kleenex box in every single room of their house, they got a problem. Okay, so this saves a ton of money over time, over eliminating any of the medications that you require just for symptom control. It's fast-acting immune modulation. You will notice in the first 4 to 6 weeks a decrease in your allergy symptoms. You might see a little spike, because keep in mind that allergy threshold. When you start doing drops and you're already symptomatic, keep in mind you're adding drops to that threshold and you're pushing it over the top. But keep in mind that you can do symptom modulation at that point with some kind of medication, but the goal is to get you off the medication as soon as possible. So as you have those symptoms, when you start your drops and you're passing that threshold, keep in mind that our goal is ultimately keep doing the drops, and eventually your symptoms will go away and your need for those symptom controlling medications vanish. They disappear. They never come back. So there's a long-term solution for higher quality health. Reduce or eliminate the allergy-related symptoms. Safer than allergy shots. There's no anaphylaxis risk with sublingual immunotherapy, of course, unless you're like drinking the whole damn bottle at once, which obviously is not what is directed. So you want to make sure that you follow the directions and do what you're told. And it can be administered safely and easily at home. Parents can put drops under the kid's tongue, and guess what? This stuff works really, really well on pets too. Atopic dermatitis is the number one cause for pets going to a veterinarian, and all you got to do is pick up their little jowls, put the drops underneath the tongue, and it works fantastic for dogs that are chewing their paws, really bad ears, hot spots, you name it. Atopic dermatitis, if the dogs are scratching all the time, it's an allergy. This can be delivered in the practice or shipped at home. So when I say practice or at home, I'll explain that to you a little bit later, but actually I might as well go ahead and explain it now. If the patient's coming into the office and you want to make sure that that patient is staying compliant, we give the doctors a $20 compliant and patient management therapy compensation, because we want to make sure that the clinic is making sure the patient stays on the program. It's really easy to get used to it and go, hey, I feel better now, and stop. That's what you don't want to do. You want to complete this all the way through, because it takes time to modulate the immune system. Your body takes time to accommodate this learning phase of being able to recognize the protein and not reacting to it. So it's going to take 12 months to get it done. The good news is it's not going to take 5 to 6 years to get it done. It'll take 12 months to get it done. That's the reason why we do the testing in 12 months when we come back. We want to see a before and after on the allergy drops. And so as far as the ease of use, when it's easy to use and it's safe to use, then you'll get higher compliance. When you get higher compliance, you get better result. And that's why you get an 80 to 90% compliance rate on sublingual immunotherapy when you only get 20 to 25% compliance from an allergy shot. So that's it for the key concepts. So now what we're going to go through is we're going to go to segment number 3, which is allergy testing.